Hello, friends. Today I'll be talking on nuances in nystagmus, and at the outset, I would like to thank the organizers for giving me this opportunity. Nystagmus is a rhythmic, regular oscillation of the eyes. It may consist of alternating phases of a slow drift in one direction with a corrective quick jerk in the opposite direction, or of a to and fro, slow, sinusoidal pendular movement. I have no financial disclosures. Nystagmus is usually classified as physiologic, pathologic, in which we have the sensory, acquired motor, and the childhood nystagmus, and the nystagmoid conditions. The physiologic nystagmus is optokinetic nystagmus or the railroad nystagmus, vestibular nystagmus, caloric or positional endpoint nystagmus, and sometimes a voluntary nystagmus. The nystagmoid conditions are the Heman-Bilshowski's phenomenon, convergence retraction nystagmus, opsoclonus, and ocular bobbing. The acquired nystagmus usually has neurological lesions underlying it, and these should be kept in mind. The important thing is that any acquired asymmetric vertical nystagmus or any nystagmus which has an oscillopsia present, the imaging should always be done. Like in this case, in which there was an asymmetric nystagmus, more beating in the right eye, and we suspected acquired conditions. We did imaging which showed a suprasellar mass or a craniopharyngioma, which could save life. When we see nystagmus in children, we usually think of the sensory nystagmus, and a thorough eye examination or a fundus and the ERG needs to be done. The other nystagmus, which is commonly seen, is the infantile nystagmus syndrome or the manifest nystagmus, and the other one is the fusional maldevelopment nystagmus. Sometimes we come across nystagmus blockage syndrome, and the other rarer ones are the spasmus nutans, seesaw nystagmus, vertical nystagmus, or acquired nystagmus. All these shown in the red are indicating or highlighting the point that imaging should always be done in these four listed conditions. The sensory nystagmus, which is usually seen, should be looked for these underlying problems in the eye, and a thorough examination, as mentioned earlier, should be done. The more common nystagmus that we see is the infantile nystagmus syndrome, which is usually bilateral, conjugate, uniplanar, worsening on fixation attempt, improving on convergence. It usually has a null point, and oscillopsia is mostly absent. It evolves in three phases from the first few months of life as a triangular phase, and then moving on to jerk nystagmus, and in between there is a pendular nystagmus for 6 to 8 months age. The infantile nystagmus syndrome, also known as manifest nystagmus, may have an eccentric null, and we should distinguish this from adduction null. And as you cover the adducting eye, the eye keeps in abduction, means it's an eccentric gaze null. As against this child, in which there is a null, and when I cover the right eye, the left eye starts beating much more, and then the head turns towards the other side to take the left eye in adduction. This is a fusional maldevelopment nystagmus. The fusional maldevelopment nystagmus usually are associated with strabismus, whether it's an infantile esotropia or intermittent divergent squint. And once the intermittent divergent squint breaks, the latent component also becomes manifest, as in this case. Infantile esotropia or IENA nystagmus syndrome or Sciancia syndrome has a situation in which there is an adduction null and the child keeps a face turn, and at the time of surgery, if we do along with the MR recession a posterior fixation, we can take correction for both the head turn as well as the esotropia. Spasmus nutans is a dissociated nystagmus. It's typically a triad of a nystagmus, torticollis, and the head turns or movements. So these have to be taken into account, and whenever you have a dissociated nystagmus in a child of this kind, imaging should always be done. The majority are benign, but we have no way to distinguish the malignant from the benign, and so always indicated to do a imaging CT or an MRI to rule out a chiasmal glioma. Nystagmus blockage syndrome is a condition in which there is an inverse relationship between the nystagmus, like in this case you see the eyes are straight, and the moment the ESO is there, the nystagmus disappears. So in an examination of nystagmus, look for head posture for distance and near, and look for associated squint or albinism. Also, these points should be kept in mind. Even the visual acuity estimation should be done binocularly always to see if binocular vision is better. Then repeat the monocular vision assessment by not covering but by using a plus occluder, a plus 4 or 6 diopter occlusion. The head turn should be measured with the help of a protractor. A changing head posture should always be looked for, as you may miss a periodic alternating nystagmus, and a full examination of 5 minutes at a stretch while the child is doing an interesting visual task should be done in order to not miss a periodic alternating nystagmus. So in the non-surgical management, we usually prescribe the glasses and make use of tinted glasses if there is an associated albinism. Contact lenses may be used for high myopes. Prisms may be tested for, but usually they do not have much advantage in the larger head turns. Auditory biofeedback and acupunctures have been tried, but they have a limited role, like these publications indicate. Medical treatment in the form of baclofen, gabapentin, and brinzolamide eye drops have been tried with limited success. Mainly, the strategies of surgical management is that which works, and the 5 principles that we use are the shifting the eccentric null, artificial divergence surgery, correcting associated strabismus, 4 horizontal muscle recessions, and the Hurtel-Deloso procedure. The plan for Anderson-Kestenbaum or shifting the eccentric null to the primary position may be done by Anderson's yoke muscle approach of recessions on both the yoke muscles, or a resections of the Goto approach, and the combination of this as a Kestenbaum approach. The surgery is usually planned at about 4 years of age before the child goes to school. So these are the various types of surgical plans. Our choice is usually for a 30 degrees face turn to do an MR recession of 9 mm and an LR recession of 12 mm of the 2 yoke muscles or the 2 eyes. Like in this case, an MR recession 9 mm and an LR recession of 12 mm in the opposite eyes have been done, and it's corrected the head posture. These are the pre-op and post-op measurements of the ENG. One should be aware of the periodic alternating nystagmus, as if it is missed, we may have a surprise on the other day of having a face turn shifted to the opposite side. But if you have done augmented Anderson's procedure, you can easily do the other 2 opposite muscles and correct it to 4 horizontal supramaximal recessions. An eccentric null with strabismus, one should look into the fact that which is the dominant eye, as the nystagmus surgery would be done on the dominant eye and the strabismus surgery can be done on either of the eyes. For a vertical face turn, the same principle we operate on the vertical recti, the superior rectus or the inferior rectus, and for a head tilt or oblique Kestenbaum procedure can be done by using the oblique muscles. The torticollis or head tilt in this case, as it is shown here, and the 4 muscle recessions or supramaximal recessions and the Hurtel-Deloso procedure have been tried with limited success, and in some cases it may be tried. Artificial divergence surgery is described by Spillman, and we work on the bimetal recessions of the 2 eyes to induce an innervational convergence to improve the nystagmus. So the take-home points are listed in this list, which should be taken into account in all cases. I would like to thank the organizers for giving me this opportunity for completing this mission in children to spread sight and happiness. I would like to thank you all for this patient listening.